in the period of immobilization. This phase is important to accelerate the regeneration process and properly orient the regenerating muscle tissue. The use of non-steroidal anti-inflammatory drugs during the acute healing phase is really controversial. You have to keep this in mind. Am I clear so far? عم تسمعوني؟ الو دكتور صالح، دكتور صلاح، الو am I clear؟ عم تقشعوا سكرين، ما في حدا مجاوب. Hello. Non-steroidal anti-inflammatory drugs can provide analgesia, reduce inflammation, and help prevent ectopic ossification. But, I repeat, but concerns of delayed or weakened healing have been expressed. Some studies have reported no adverse effects of short-term non-steroidal anti-inflammatory drugs use on the healing process. Evidence of later decreased growth and healing exists. However, rarely is non-steroidal anti-inflammatory drugs use needed for longer than 3 to 7 days following injury. Only we give it for 3 to 7 days. We don't like the long-term side effects of non-steroidal anti-inflammatory drugs. We know that it helps in preventing heterotopic ossification, but we don't like to use it on long periods. What about muscle contusions? Contusions causing significant muscle damage nearly always occur in one of 4 muscles: the quadriceps, the hamstrings, the adductors, or the calf muscles. Contracted and stronger muscle will absorb force better and incur lesser severe injuries. What about quadriceps contusions? These should be braced in 120 degrees of flexion for 24 hours to limit hematoma formation. Return to play from quadriceps contusions average 13 days for mild, 19 days for moderate, and 21 days for severe contusions in West Point cadets. So you have to keep this in mind. Myositis ossificans occurs in 9 to 15% of contusions. Clinically, myositis ossificans should be considered if improvement is not seen in 1 week, or if symptoms worsen in 2 to 3 weeks post-injury. Radiographic evidence be present as early as 3 weeks post-injury, but may take as long as several months to become evident. Non-steroidal anti-inflammatory drugs can be used at the time of acute injury to reduce the possibility of myositis ossificans development. So keep this in mind. Rehabilitation for contusions should follow that of low-grade muscle strains and should include trunk stabilization, agility exercises, and eccentric strengthening. Briefly about hamstring strains and avulsions. I think any busy orthopedic surgeon could say that I have seen at least 1 or 2 cases of avulsions of the hamstring muscles. Briefly about the anatomy. The hamstrings are composed of 3 muscles: the semimembranosus, the semitendinosus, and the biceps femoris. The biceps is formed by a short head and a long head, which are innervated by 2 different nerves. The peroneal supplies the short head and the tibial branches of the sciatic nerve, respectively. So the short head is supplied by the peroneal nerve, and the long head is supplied by the tibial nerve. Long head of the biceps and semitendinosus. Keep this in mind. The long head of the biceps and semitendinosus join proximally to form a single conjoined tendon that inserts on the medial portion of the ischial tuberosity, but they separate into distinct tendons approximately 5 centimeters distally. So think of it. The long head of the biceps and the semitendinosus, they have a single conjoined tendon, and this inserts on the medial portion of the tuberosity. So when you have an avulsion injury, it is an avulsion of both tendons, the long head of the biceps and the semitendinosus. The semimembranosus inserts on the lateral portion of the tuberosity. So the medial portion is by the semitendinosus and the long head of the biceps. So one is inserted medially, the other is inserted laterally. This creates a force on the tuberosity when it is under severe strain. This shows it. The biceps femoris, the semitendinosus, of how they arise from the ischial tuberosity, and you have the semimembranosus, which is more to one side and arises again from the ischial tuberosity. You have to think of that the forces of strain put together by these 3 tendons or muscles on the ischium so much at the time during sports injuries that you can have it in avulsion of the ischium. You have to keep this in mind. The hamstrings course medially to the sciatic nerve as they enter the thigh. This anatomic relationship is clinically significant because it is common to have sciatic nerve irritation in chronic avulsions from traction injuries and scarring. So you have to think of the sciatic nerve in relation to these tendons. If they are avulsed and they have scar formation, the nerve may be irritated by the scar tissue, and the patient will have pain referred to the lower extremity. And you could be confused with the disc rupture. You have to put a differential diagnosis. Distally, the hamstring tendons cross the knee joint, where they serve as knee flexors. The hamstrings are maximally stretched with combined knee extension. Of course, knee extension stretches the posterior aspect of the thigh. And if this is associated with flexion of the hip, you'll have such a strain on these muscles, such a pull on the muscle, namely the semitendinosus, the long head of the biceps, the semimembranosus, because they pass posteriorly to both the hip and the knee. So keep in mind, the strain is on these three muscles. By just extending the knee and flexing the hip. Look at football players. Now you're watching the Championship of Europe. Observe the football players. Many times they have injuries with the knee in extension and the hips in flexion. Then you will kind of wonder, did this candidate have an avulsion of the ischial tuberosity? You should keep this in mind tonight when you're watching the football championship of Europe. Also in water skiing, also they can cause the same thing when the knee goes into extension at the same time as the hip is in flexion. This would cause such a strain and cause the avulsion. I'm repeatedly telling you this so that you'll never forget it. Patients with hamstring injuries, the history reveals posterior hip pain located deep in the buttocks. Patients would typically report that a pop, a tearing, or pulling occurred at the time of injury, just as you will get with the rupture of the Achilles tendon while playing tennis, as if somebody has shot you or punched you in the area. With avulsion injuries, patients occasionally describe a feeling as though they have sustained a gunshot injury to the area of the ischial tuberosity. If you ask the patient to sit down, he will have pain. Why? Because he's flexing the hip. He's stretching the origin of these hamstring tendons. And therefore, the force on the avulsion is high. Keep this in mind. What about the physical examination? Inspection can show mild to severe ecchymosis over the posterior buttocks. In the examination, finding of ecchymosis is associated with a prolonged return to competition, which would be more than 4 weeks. Palpation over the ischium or musculotendinous junction will reveal tenderness and a possible tendinous defect in the avulsion injuries. Patients with hamstring strains will feel tenderness more in the mid-thigh at the elongated musculotendinous junction of the biceps femoris. This is a slide which shows you the hamstring muscles as they have been strained. You can see the relation. They originate from the ischium as the hip flexes and the knee is in extension. The stretch force on these muscles causes a strain. There will be an injury. There will be a bluish discoloration. There will be severe tenderness when the sportyish man sits on his buttocks. Patients with more severe injuries ambulate with a stiff-legged gait to avoid hip flexion. We like to avoid hip flexion. We like to avoid it because it produces stretching. The range of motion and strength testing not only confirm the diagnosis, but also help determine when return to sporting activities is appropriate. Keep this in mind, please. Keep this in mind. Strength testing at 15 degrees is important. And 45 degrees can help determine the severity of the tear. Knee extension is often limited compared with the opposite extremity. The sciatic nerve, particularly the peroneal division, should be examined by testing ankle dorsiflexion strength and performing a straight leg raise for radicular pain. Don't forget to differentiate it from a disc rupture. This is how we do test these. You have to promote extension, see the amount of tenderness and pain that the patient has and the weakness. You ask the patient to flex the knee when he's in the prone position to evaluate the strength of the hamstring muscles. You compare one side with the other. Don't forget it. Imaging. Plain radiography is usually not routinely performed, but can be used to identify bony avulsion injuries as the ischial tuberosity. Bony hamstring avulsions from the ischial tuberosity are common before the ischial apophysis closes during early adulthood, namely ages from 20 to 25 years, but can occur as a bony avulsion after skeletal maturity. If you look at this X-ray, if you look at the left side, the ischium, you see that there is an avulsion of the ischial tuberosity. Don't forget the origin of the semitendinosus, the long head of the biceps, and the semimembranosus. The force on the bone can be high and result in an avulsion. MRI is useful in characterizing hamstring strains. Hamstring tears have intermediate signal intensity on T1 weighted imaging and a high signal intensity on T2 imaging. So don't forget this. MRI can reliably determine the number of torn tendons and the amount of tendon retraction, but was not shown in a systematic review of grade 1 and 2 injuries to predict re-injury or the return to specified form of sports. Chronic injuries can be delineated with MRI based on the presence of fatty infiltration, scarring, and reducing hamstring volume. Look at this MRI section of the extremities. Look at the left side, you see a normal black hamstring tendon connected to bone. Look on the right side. You see there's an avulsion of the hamstrings, of the long head of the biceps, of the semitendinosus and membranosus. And you see that there's fluid where the tendon should be present. Look at the yellow arrow. You see that there's increased signal intensity. So MRI will help us tremendously in making a diagnosis. What about the classification? Proximal hamstring injuries can be divided readily into muscular tendinous junction or avulsion injuries. Muscular tendinous junction strains comprise most, up to 90% of these injuries. And at the three hamstring tendons, the long head of the biceps, the femoris, is the most commonly injured site. So if I ask you a question, which hamstring group of muscles are most commonly injured, you should mention the long head of the biceps, femoris, the semitendinosus, and semimembranosus. Avulsion injuries from the ischial tuberosity comprise 12% of such injuries and are less common, but are associated with a worse prognosis and different surgical recommendations than are musculotendinous junction injuries. A treatment algorithm for hamstring injuries is shown in this slide. You have to realize you could have an avulsion, the number of tendons involved, and the amount of retraction. If it's one tendon, rehabilitation is the treatment and return of sports in 4 to 6 weeks. If it's two tendons with retraction, if it's less than 2 centimeters, you could treat them conservatively. If it's more than 2 centimeters and also 3 tendons are involved, then you have to treat it surgically. This is as far as avulsion is concerned. Now move to the other side. You have the musculotendinous junction injuries. They need rehabilitation. The strength is greater than 80%. Hamstring to quad ratio is greater or equal to 50%. They have full knee extension and minimal pain. You return the candidate to sports as tolerated. Keep this in mind. 2 forms, one avulsion and injuries, the other injury of the musculotendinous junction. Look at this algorithm. This would tell you when to operate, when not to operate, how to treat conservatively, and when to let the candidate return to sports. Avulsion injuries can be strictly tendinous or contain an avulsed portion of bone. Subclassification of proximal avulsions is also presented in the next slide. With single tendon avulsions, retraction is unlikely because they're connected to one other, these tendons, these hamstring tendons, because the torn tendon scars to the intact tendons, producing a functional musculotendinous unit. Therefore, single tendon avulsions rarely require surgery. Please don't forget this. This is the Wood classification of hamstring injuries. One, you have bone avulsion. 2, the musculotendinous avulsion. 3, you have an incomplete avulsion. And 4, you have a complete avulsion. There's no retraction. And 5, you have a complete avulsion with retraction. This is a classification only according to the degree and location of the injury. The potential for tendon retraction and impaired functional healing increases proportionally to the number of avulsed tendons. Retraction greater than 2 centimeters requires 2 or more completely torn tendons, and the retraction greater than 5 centimeters is indicative of a 3-tendon avulsion. So the distance tells you or gives you an idea of how many tendons are avulsed. If it's greater than 2 centimeters, there is 2 or more completely torn tendons. But if the avulsion is more than 5 centimeters, you have to think of avulsions of the 3 tendons: the long head of the biceps femoris, the semitendinosus, and semimembranosus. Strength deficits with non-surgical treatment are clinically detectable when all 3 tendons are avulsed. Look at this slide. This is a coronal and axial views which depict the appearance of hamstring avulsion injury with retraction. Look at the amount of retraction. Compare it to the opposite side. You see that the whole group of 3 tendons have retracted. If this is more than 5 centimeters, you should operate. If it's less, then you can depend on it healing to the neighboring tendon and scarring, so you won't lose much in the force applied. What about the treatment? Muscular tendon joint injuries and single tendon avulsions of the hamstrings can be treated successfully without surgical intervention. The initial 3 to 5 days following injury are devoted to rest, ice, relative immobilization, compression, and analgesics. Weight healing as tolerated with crutches is permitted until pain-free ambulation without a limp is achieved. The ability to ambulate unassisted without pain 1 day after injury associated with shorter recovery time than is inability to do so. Clinical findings such as bruising, hematoma, tenderness to palpation, a lack of complete range of motion, and pain with isometric limb lengthening 3 to 5 days following injury are predictors of a prolonged recovery, more than 4 weeks. Rehabilitation following the acute phase should focus on agility training and eccentric exercises, which have been shown in randomized trials to return athletes to competitive sport more quickly than traditional hamstring strengthening protocols. Corticosteroids and platelet-rich plasma injections have been reported to expedite a return to play following hamstring injuries of the musculotendinous junction. Corticosteroid injections were reported to be safe in 53 National Football League (NFL) players with focal hamstring musculotendinous injuries. These players all had a significant hamstring injury evidenced by a palpable defect on physical examination, but over 80% were able to return to play within a week of injury. Despite the beneficial effects found in this case series, concerns raised by experimental studies question the practice of corticosteroid injection for acute hamstring injuries. Delayed hematoma evacuation. I want to know, I have a pause. What do we mean by this? عم تسمعوني؟ Hello.
واضح يا دكتور، واضح.
I would like to tell you, in one of the slides, there was a fault in printing. It is weight bearing, which should be decreased, or when the candidate is able to bear weight, it is clear.
اوكي دكتور.
Slides are not obvious. جيتني هلا عم بيقولوا لي slides are not obvious. Is this so? ما بعرف. Okay, I'll carry on.
اوكي carry on. السلايدات واضحه يا دكتور.
السلايدات واضحه. Okay. Delayed hematoma evacuation, skeletal muscle necrosis, and reduced biomechanical strength all have been found as a result of glucocorticoid injections. So,
دكتور
in this NFL group, they made
John,
corticosteroid injections. We know that steroids weaken muscles.
دكتور جون سامعني؟
Are you seeing now? شايفين؟
اوكي السلايد فريز على السلايد اللي هو ويت بيرنج ويت
هيك انا ما عم برجع فرجيني لا تشوف، وقف لا تشوف.
اوكي السلايد فريز يا دكتور، توقف السلايد على السلايد اللي هو ويت بيرنج as tolerated with the crutch.
وقف خليني ارجع اشوف. والله ما عم بقدر لاقيها، خلينا نشوف. اوكي فاذا رح برجع، خلينا نبلش هون. surgical indications شايفينها؟ slide surgical indications.
الآن السلايد الشاشة متوقفة يا دكتور، بلاك.
مش مظبوطة. لكن I'm going to go out and then come in again. شو رأيكم؟
اوكي دكتور أفضل.
اوكي. هلا شايفين
Yeah, it's clear.
surgical indications?
Okay.
Okay. Please let me know when the slides don't move with the lecture.
Okay, doctor. Thank you.
Complete hamstring avulsions involving all 3 tendons or 2 tendons with significant retraction may benefit from early surgical repair. Ischial apophyseal avulsions are treated with surgical repair only if they are displaced more than 1 to 2 centimeters. If they displace only 1 to 2 centimeters, don't operate. Keep this in mind. And I've seen many cases which were hardly displaced. By operating, you're endangering the sciatic nerve because the sciatic nerve will be in the scar area. A systematic review of proximal hamstring avulsions found superior results in patients treated with acute repair compared with those treated with chronic repair or non-surgical management. Acute surgical repair performed within 4 weeks of injuries was found to have a higher return to pre-injury levels of sport. This is if the avulsion is more than 1 to 2 centimeters. We like to repair them acutely because they will return to sports in 96%. If you wait and you see that your ischial fragment is more than 2 centimeters, and then you want to do the repair, there are 2 factors you have to consider. The sciatic nerve would lie within the scar tissue, and you can injure it. And 2, the results are not so good. There is a definite decline in the candidate returning to sports. Acute surgery was associated with better patient satisfaction, subjective outcomes, pain relief and strength, and less chance of re-rupture. Selection bias inherent in the retrospective series design was present in all studies included in this review. So please keep this in mind. I repeatedly would like to state, don't repair an ischial avulsion if it's less than 1 to 2 centimeters. If it is more, try and repair it during the acute phase. Don't wait until the chronic phase and then come in and say, I want to repair it, because the results are not good. There will be so much scar tissue that you cannot re-lengthen the portion which is avulsed, and you will be endangering the sciatic nerve. Keep this in mind, please. For description of the number of avulsed tendons between groups also could bias these results and explain the differences found. Post-operative care in these patients prevents simultaneous hip flexion and knee extension. It protects the repair. Hip or knee braces can be used to prevent stress on the repair. A knee brace locked in flexion may suffice to limit active knee flexion and is generally better tolerated. The brace is discontinued in 6 weeks post-operatively. At 6 weeks, stretching and range of motion exercises are initiated. Strengthening is introduced in 3 months post-operatively, with the goal of returning to sport at 6 to 9 months post-operatively. Quadriceps strains and avulsions. There are 4 quadriceps muscles. These are the rectus femoris, the vastus medialis, the vastus lateralis, and the vastus intermedius. The bipinnate rectus femoris is the most susceptible to strain or avulsion because it is the only quadriceps muscle that crosses the hip joint and serves as a hip flexor in addition to being a knee extensor. As with the hamstrings, this anatomic relationship places rectus femoris at increased risk for strain compared with the vastus muscles, which are purely knee extensors. I repeat, as with the hamstring, this hamstring and this anatomic relationship places the rectus femoris, which arises from above the hip joint, at increased risk for strain compared with the rest of the vastus muscles, which are purely extensors of the knee. In fact, only 2 cases of vastus lateralis avulsions have ever been reported. The vastus intermedius is the muscle which is most, or the vastus rectus femoris is the muscle which is mostly injured due to its 2-joint involvement. Don't forget this. The direct head of the rectus femoris originates from the anterior inferior iliac spine, whereas the indirect head originates more laterally from the supraacetabular ridge adjacent to the acetabular labrum. This shows you the origin of the rectus femoris. You see the upper line points to the anterior inferior iliac spine. The lower line points to the groove in the superior to the acetabulum. So it has 2 heads and it bypasses 2 joints. And this is the muscle which is most injured and torn, while the others are rarely torn, the vastus lateralis, medialis, and even the intermediates. Why? Because they originate distal to the hip joint and therefore only act on extension of the knee. This is an axial CT2 weighted MRI, which shows a bull's eye lesion associated with injury to the indirect head of the rectus femoris muscle. The indirect head is more commonly injured. Distally, the indirected head extends nearly 2/3 of the length of the entire muscle as a central intramuscular tendon, whereas fibers from the direct head blend anteriorly on the periphery of the muscle belly. This anatomy is important to appreciate because central tendon injuries of the indirect head are associated with a longer return to play than are the peripheral injuries. So I would like to go back here and stress this. You have the anterior portion arising from the anterior inferior iliac spine, and you have the other portion arising, the other section is arising from the groove superior to the acetabulum. So it tells you that you should know what the direct and indirect rectus femoris insertion is. Okay, keep this in mind, please. Now, this anatomy is important to appreciate because central tendon injuries of the indirect head are associated with longer return to play than are the peripheral injuries. Patient evaluation. Quadriceps injuries occurred during kicking. فكروا فيها هلا بالفوتبول انتوا عم تحضروا عشية. Kicking promotes a lot of strain on the rectus femoris muscle, or it can occur as a result of sudden deceleration from a sport. Salsa players and football kickers typically are affected. The injury mechanisms include a sudden forcible block to a kicking motion or kicking the air instead of the intended object. Risk factors include insufficient warm-up, poor muscle conditioning, and previous tears. Physical examination demonstrates tenderness to palpation around the anterior inferior iliac spine. Ecchymosis and palpable defects can be seen in more severe injuries. Rarely in chronic cases, the avulsed proximal tendon can be palpated distally as a mass that can sometimes mimic a tumor, but a history of trauma helps to differentiate the two pathologies. Radiographs are not obtained routinely for isolated injuries that follow the expected clinical course. Radiographic workup should be considered for palpable defects near the anterior inferior iliac spine, recurrent injuries, and young patients with risk for avulsions. MRI helps to characterize the musculotendinous junction injuries and proximal avulsions. Increased signal on fluid-sensitive imaging within the indirect head is the most common MRI finding. Injuries of the indirect head can involve a long segment of the rectus muscle centrally that can result in a bullseye sign on axial imaging. Longitudinal scarring of pseudocysts and hematoma formations are detected by MRI and give us a point or knowledge or a awareness of the rupture. Increased signal on and fluid sensitive imaging within the indirect head is the most common MRI finding. Injuries of the indirect head can involve a long segment of the rectus muscle, which centrally that can result in a bullseye, as I mentioned in the pseudocyst. Classification. Proximal rectus femoris injuries are classified either into musculotendinous junction or avulsion injuries, similar to proximal hamstring injuries. Musculotendinous injuries can involve the indirect head, the direct head, or the conjoined portion of the tendon. Avulsions occur with or without a bony portion of the anterior inferior iliac spine. In the skeletally immature patients, the anterior inferior iliac spine avulsions account for 20 to 25% of all avulsion injuries, and nearly 50% of all pelvic apophyseal avulsions. Proximal avulsions also can occur less commonly in skeletally mature individuals. Anterior posterior radiograph shows an avulsion of the right anterior inferior iliac spine in a skeletally mature patient. We see this more often in children. Look at the right-hand side. Look at the avulsion of the anterior inferior iliac spine, of how it's separated from the parent bone. But be aware that these should not be repaired. They should be observed until they heal, and then the individual could be very well without surgery. Treatment. Muscular tendinous injuries are treated non-surgical with a graduated rehabilitation program aimed at returning athletes to competition 6 to 10 weeks after the injury. Return to participation was shown to be proportional to the length of the central epineurosis tear in the Spanish saucer layers. Okay. Am I clear so far? Are you seeing the last slides?
Yes, doctor.
Are
It's
you
clear. It's clear.
You
yes.
are seeing?
Yeah.
Okay. Now, let us go over here. Suggested non-surgical rehabilitation for rectus femoris injuries. Okay? In week 1, you have protected weight bearing with crutches, ice, anti-inflammatory medications, all forms of modalities of physiotherapy, and passive range of motion. Weeks 2 to 4, gait training, active range of motion, and isometric exercises. In weeks 4 to 6, resisted strength training, running, and functional drills. And finally, in the 6th to 10th week, they return to play. So this is how you would treat a incomplete or a rectus femoris tear, which is not markedly separated. Every 1 centimeter increase in tear length greater than 4 centimeters result in an average 5-day increase in return to sport. Proximal injuries of the rectus femoris require a longer recovery period than do distal tears, by an average of approximately 1 week. Anterior inferior iliac spine injuries, avulsions with less than 2 centimeters of tendon retraction can and should be treated non-surgically. I repeat, anterior inferior iliac spine avulsions, less than 2 centimeters, treat non-surgically. Retractions of more than 2 centimeters are more likely to develop non-union or cause subspinous impingement and should undergo internal fixation. Subspinous impingement can cause pain and reduced hip range of motion because the femoral neck or greater trochanter impinges on a low-lying anterior-inferior iliac spine. Subspinous impingement is most common when the anterior-inferior iliac spine extends to the level of the acetabular rim, which is type 2, or past the rim, which is seen most frequently as a sequelae of healed avulsion injuries. Type 3. Surgical indications for chronic anterior iliac spine avulsions include reduction and internal fixation of symptomatic non-united fragments, resection of exostosis that cause functional impairment, and painful subspinous impingement. So if it's more than 2 centimeters, then you have to treat because you can get impingement and pain. If it's less than 2 centimeters separate from its origin, treat it conservatively. Acute surgical reattachment of purely tendinous avulsions has been reported in several cases. In special case series with good results. Other studies have shown good results with non-surgical management alone, however, even in high-level kicking athletes. In a series of 4 Sosa players and 1 hurdler treated with acute repair at less than 102 days, all were able to return to their previous activity level between 5 and 10 months after surgical repair. So you should judge when to operate and when not. If it's not displaced significantly, meaning more than 1 to 2 centimeters, treat conservatively. Otherwise, treat it early surgically. Authors of a 2012 study reported on 10 professional salsa players who underwent repair of an avulsed rectus injury with direct suture repair or bone anchors. At a mean follow-up of 35 months, they found fewer re-injuries in the surgical repair group. In contrast, another study reported on NFL players, including 2 players who were treated non-surgically. The NFL players were able to return to professional sports, football, at a mean of 70 days. Studies between surgical repair and non-surgical management are needed to compare the 2 treatment options. Chronic injuries that fail to improve may require surgical management. A pain-free return to sport has been reported in a salsa player treated with surgical repair of a chronic musculotendinous junction injury. surgical debridement of the symptomatic tendon stump also can enable a return to high-level sport. Authors of a 2011 study reported on 5 collegiate athletes who underwent debridement of chronically painful retracted indirect heads. Although all 5 improved, only 1 patient returned to sport without recurrent pain or reduced athletic ability. Symptomatic pseudocyst formation, which can occur around the central tendon of the indirect head, can be surgically excised with good results. In summary, muscle injuries are common in sports and frequently involve areas around the hip. Musculotendinous junction injuries can be treated non-surgically, initially with conservative management, including ice and rest, and the full rehabilitation program. It focuses mainly on agility training, trunk stabilization, and eccentric strengthening. The return to sport should be determined by physical examination criteria, including minimal pain, full range of motion, and near symmetric strength to prevent injury. Full recovery may take several weeks in some cases. Avulsion injuries should be recognized and treated differently than low-grade strains or contusions, according to specific guidelines for the affected muscle. What are the key study points? Hip muscle strains are commonly encountered in sports. Treatment is largely non-surgical, rise acutely, followed conservative, rise meaning multiple conservative managements of physiotherapy, acutely followed by rehabilitation, focusing on agility training, trunk stabilization, and eccentric lengthening. This should be a very gradual process. Complete hamstring avulsions involving all 3 tendons, keep this in mind, or 2 tendons with significant retraction may benefit from early surgical repair. If it's 1 tendon alone, it isn't retracted or very slightly. This does not need surgical management. If 2, yes, you measure the distance of displacement, they may benefit from surgery. And 3 tendons, namely the long head of the biceps, the semitendinosus, and the semitendinosus and the semimembranosus, all these muscles which are attached to the greater to the ischial tuberosity should be considered for surgical management. It depends on the gap and the amount of displacement, and also on the acuteness. If it's acute, the result is good, better, and the chances for recovery are high, and the chances for re-injury drop. The earlier treated, the better it is. Keep this in mind. Don't wait until full scar tissue has formed in these markedly displaced avulsions or displacement. Keep this in mind. Rectus femoris strains and avulsions can both be managed successfully, even in high-level kicking athletes with 6 to 10 weeks of rehabilitation. Writes, rehabilitation. The length of the central aponeurosis tear in the musculotendinous junction strains predicts return to play. Athletic hip injuries. Any questions so far? Would like to know. I'm going to look at the chat to see if there's any questions. No, there's no. Who can see your message going on? Okay, so there are no questions. I'm still waiting. Are there any questions?
No question, doctor. استمر, doctor.
Okay, so we'll carry on
Okay.
into athletic injuries of the hip.
Okay, doctor.
I think now it will become more interesting.
Okay.
I want to mention at this stage something important. I'm not an arthroscopist. I do arthroscopy, but I don't do it on a continuous basis. I'm going to give you knowledge on arthroscopy as far as I understand it, as far as what we expect from a resident in training should know. In case he wants to know more, then he will go into the subspecialty of arthroscopy. I would try and give you the maximum, but not too much. Hip arthroscopy has been one of the most rapidly developing fields in orthopedic surgery over the past decade. As improved equipment and evolving techniques have made the procedure safe and relatively easy to perform, indications have continued to expand. But I want you to know, hip arthroscopy is not the same as knee arthroscopy. It's more difficult and you have more complications. It is a continuous, knowledgeable curve and rising. You need sufficient training to be able to do it with confidence. Furthermore, as the understanding and appreciation of femoroacetabular impingement, the most common indication for hip arthroscopy, have evolved. The diagnosis has become better recognized and surgical outcomes have improved. The current indications for hip arthroscopy address pathology in the central, peripheral, and peritrochanteric compartments of the hip joint. So it's becoming broader and broader. Central compartment pathology includes labral tears, loose bodies, ligamentous tears. We should know that ligamentum teres tears is becoming a diagnostic problem, and it gives us multiple symptoms, which I'll be telling you about. Chondral defects and pincer lesions associated with femoroacetabular impingement. Peripheral compartment pathology includes CAM lesions associated with femoroacetabular impingement, capsular laxity associated with hip instability, loose bodies, and recalcitrant internal snapping hip, secondary to chronic iliopsoas bursitis. So we have a broad area in which we can treat by hip arthroscopy. And this is grouped into peripheral compartment pathology. Trochanteric compartment pathology includes recalcitrant trochanteric bursitis, tears of the gluteus medius and minimus, and painful external snapping hip. Successful surgical outcomes in these compartments have expanded the application of endoscopic techniques to other conditions, including proximal hamstring repairs and sciatic nerve decompression in the deep gluteal space. The portals for hip arthroscopy have evolved to improve access and safety. In general, the central and peripheral compartments can be accessed through 2 or 3 portals. This slide marks the various portals, and you can see the anterolateral portal, which is AL, is a mainstay of hip arthroscopy access and visualization, and most surgeons use some variation of an anterior portal for instrumentation. Several accessory portals also have been described, and you should become well acquainted with each of the portals. The anterolateral portal is typically the first portal established, using anatomic landmarks and fluoroscopy to determine the appropriate trajectory with which to enter the joint. Typically, this portal is 2 centimeters anterior and 2 centimeters distal to the greater trochanter, and has the objective of entering the joint parallel to the sorsal without violating the labrum. The anterior portal typically is made next, using a spinal needle for localization and fluoroscopy, localizing the needle via an inside-out technique through the anterior triangle as in other joints. The key landmark is a line parallel to the femur extending distal from the anterior superior iliac spine. Remaining lateral to this line will minimize the risk to the femoral neurovascular bundle. And the more lateral the portal is, the farther away it is from the lateral femoral cutaneous nerve. So you could damage these, the neurovascular bundle and the lateral femoral cutaneous nerve. Be careful. Draw the line from the anterior superior iliac spine in line with the femoral shaft and go lateral to this. This line will divide critical zones from non-critical. The position of the anterior portal varies and can be placed farther distal and lateral to facilitate anchor placement, particularly for 2 portal approaches. Additional portals include the distal anterolateral portal, which is typically 4 to 5 centimeters distal to the anterolateral portal. This portal provides a safe trajectory for anchor placement in the acetabulum and provides easy access for cam resection. This shows you of how a needle is being put parallel to the dorsal. You have to go lateral to it to avoid the neurovascular bundle and the lateral femoral cutaneous nerve. These are the posterolateral portal, you have the anterolateral portal, and you have the medial anterior portal. All these portals should be done very carefully. This shows you lateral projection of the body, shows you the anterior superior iliac spine at the extreme proximal end and the upper end. The anterior portal is directly in line so as to avoid the structures. Medial, you have the anterolateral portal, which is in front of the greater trochanter, and you have the distal anterolateral portal shown over here. Of course, you have to apply traction on the extremity, and then you can do your arthroscopy. This shows it on a patient where a needle is used as a guide and your scope is being inserted. These are the portals. Don't forget them. This shows you the various portals of how, when they're inserted, these are the instrumentation that is used. The third portal is placed a few centimeters proximal to the anterolateral portal and offers a different trajectory into the central and peripheral compartments. The trochanteric space can be accessed via the same anterolateral portal as well as via the posterolateral portal, which is 2 centimeters posterior and 2 centimeters distal to the greater trochanter. You have to look into drawings, analyze, and repeatedly review the portals in your mind to be able to do them. A third portal, distal to the vastus ridge insertion of the vastus lateralis, provides a good viewing angle of the gluteus medius and minimus repairs while working through the anterolateral and posterolateral portals. Hip arthroscopy has a unique set of complications that differ from those of other joints because of the hip arthroscopy has a unique set of complications. These differ from all other joints. You need a steep learning curve, as I mentioned at the beginning of my talk. Don't forget it. The techniques required to access the deep, highly congruent joint through its thick, soft tissue envelope and the longer surgical times that occur. So, what are the complications that we get with hip arthroscopy? And that's why I hated doing it throughout my training. You can have a iatrogenic chondrolateral injury. You can have neuropraxia. You can have inadequate femoral and anterior impingement under resection in femoral acetabular impingement. I'll tell you this, I've done resections of CAM under arthroscopy, and I've done them open. If you ask me, which one do I prefer? Definitely me, as a non-arthroscopist, I would prefer in open, because you can judge exactly the amount you have resected. It is embarrassing when you do a follow-up on your patients and you find that you have not resected sufficient count, or when you have resected too much and you have a stress fracture. The sequela of femoral acetabular impingement over resection includes iatrogenic instability and femoral neck fracture. You have heterotopic ossification, you can have deep vein thrombosis, pulmonary embolism, osteonecrosis, and abdominal compartment syndrome, femoral acetabular impingement. Iatrogenic chondrolateral injury can occur while the surgeon is gaining access to the central compartment. It was the most reported complication in one systematic review. And this is well known to occur. Don't forget this, that you can have a chondrolateral injury. Another common but transient complication following arthroscopy is neuropraxia, with incidence approaching 50% in one series. Don't forget this. The lateral femoral cutaneous nerve is the most commonly involved. It is unclear whether lateral femoral cutaneous nerve neuropraxia is related to direct injury from the portal placement traction, from the portals and cannulas, swelling associated with arthroscopy, or a combination of causes. But the lateral femoral cutaneous nerve neuropraxia is now considered by many hip arthroscopists to be a sequela of arthroscopy rather than complication. Permanent injury is less than 5%, however. Pudendal neuropraxia also can occur even with short traction times, especially in stiff pre-arthritic hips. Traction injuries related to the post, which are substantial but avoidable, also include skin and soft tissue necrosis. I'll tell you, the amount of traction that we apply and the force on the pole could be tremendous, just to open the hip joint. And this can cause necrosis around the scrotum and soft tissue necrosis around the thigh, proximal thigh. Inadequate resection in femoral acetabular impingement surgery, more commonly on the femoral side, is the most common reason, for revision hip preservation surgery. Fluoroscopy, hip rotation, and the performance of a T-capsulotomy allow visualization of the CAM lesion in its entirety and minimize the risk of an inadequate resection. The most common reason for reoperation following hip arthroscopy is conversion to total hip arthroplasty. Whether conversion to total hip arthroplasty is a complication related to hip arthroscopy or merely a progression of the natural history of femoral acetabular impingement remains unclear. Rare but catastrophic hip arthroscopy complications include femoral neck fracture, abdominal compartment syndrome, iatrogenic instability, including hip dislocation, thromboembolic disease, fatal pulmonary embolism. Acetabular-labral tears. Acetabular-labral tears have been shown to be a substantial source of pain and disability and comprise the most common pathologic finding at the time of hip arthroscopy. This is an arthroscopic view of the acetabular-labral tear, which is common finding at arthroscopy and typically occurs anterior and anterolateral. In B, you have an arthroscopic view which shows acetabular-labral repair, which is essential to restore multiple functions of the labrum. The acetabular labrum is a triangular fibrocartilaginous ring which is attached firmly to the acetabular rim and encompasses nearly the entire acetabulum, except for the most inferior aspect, which is bridged by the transverse acetabular ligament. The labrum deepens the acetabulum. It increases coverage of the femoral head and plays a role in shock absorption, joint lubrication, and pressure distribution. Its most critical role may be the creation of a negative pressure seal with the femoral head, which aids in joint stability. You can compare it to the labrum about the glenoid fossa. It creates a negative pressure and gives you additional stability, plus the full coverage that deepens the area, and it also gives you stability. It is also involved in joint lubrication and pressure distribution. Removal of the labrum. I want you to stick this deep in your head, that removal of the labrum has been shown to lead to a shift of the femoral contact point toward the acetabular rim. So it increases the chances of subluxation. A decrease in the intra-articular fluid pressurization. In other words, it removes the negative pressure that maintains the head within the joint. Loss of lateral restraint to the femoral head motion. It increases contact stresses between articular cartilage and the femoral head and the acetabulum by 92%. Put these 4 points in your head concerning the removal of the labrum, of what harm comes to it. You could provoke a degenerative process, you could provoke an unstable hip, you could provoke even a limp in these patients, and you speed up degeneration of the hip joint. The labrum is injured most often in femoral acetabular impingement and acetabular dysplasia. Hip trauma leading to labral tear generally involves a high energy contact mechanism, which results in a frank dislocation or subluxation. Traumatic hip instability is frequently associated with chondral lesions to the femoral head and acetabulum, analogous to those seen in shoulder dislocation. Sports that require a great deal of hip torsion can lead to capsule attenuation and laxity secondary to repetitive microtrauma. Look at football plays of how they twist and turn and twist and turn. This would lead to capsular attenuation and laxity. Attenuation of the capsule leads to more instability of the joint in which the femoral head subluxates anteriorly and rides on the anterior superior labrum. Keep this in mind, please. Micro instability can also occur outside of sports in patients with collagen disorders such as Ehlers-Danlos syndrome, Marfan syndrome, and Down syndrome. They have extremes of laxity and micro instability. Degenerative labral tears are analogous to degenerative meniscus tears in the knee and are frequently associated with diffuse articular changes in an arthritic joint. Degenerative labral tears are thought to be extremely common in the aging hip and likely occur early in the arthritic process. Iliopsoas impingement on the anterior hip joint recently has been suggested as an additional mechanism for labral tears. The authors of a 2011 study described an atypical labral tear pattern in a series of patients in which the labral tear occurs on the anterior acetabulum directly beneath where the iliopsoas tendon crosses the hip joint. Unlike the common location in femoral acetabular impingement and dysplasia, which is more superior on the anterior acetabulum. The presentation was similar to that of femoral acetabular impingement with groin pain, inflection, adduction, and internal rotation. So you have to differentiate the two conditions. These patients were successfully treated with an iliopsoas lengthening and a labral debridement or repair. In the pediatric literature, several case series describe labral tears in the association with avulsions of the rectus femoris. The reflected head of the rectus femoris is near the anterior labrum and inferior to the anterior superior iliac spine. This is theorized that a traction injury of sufficient energy can tear the labrum in this location. Several labral tear classification systems exist based on tear morphology, histology, and location. Tear patterns based on morphology have been described. Stable tear patterns include radial, fibrillated, and longitudinal peripheral tear patterns. Radial flap tears occur with an intra-articular free edge disruption. Radial fibrillated tears are degenerative tears with fibrillated free margins. Longitudinal peripheral tears are stable labral separation from the acetabular margin. Unstable tears include the buccal-handed tear. Yes, you have to really know these briefly, the types of tears of the labrum of the hip. Two types of labral tears based on the history have been described. Type 1 tears occurred at the junction between the fibrocartilaginous labrum and the articular hyaline cartilage. And type 2 tears occurred in various planes within the substance of the labrum. So one is at the periphery between it and the fibrocartilaginous and the hyaline cartilage and the fibrocartilaginous region. So you have to pay attention to this. One which is at the periphery, one is in the labrum, completely various multiple tears. Labral tear classification based on the location is described by the tear position in relation to the acetabulum. Anterior labral tears have been prevalent in most of the studies because of their association with femoral acetabular impingement. The diagnosis of labral tear often can be made clinically. Patients may report mechanical symptoms such as clicking and catching, as well as growing pain in positions of hip flexion. Don't forget this. I'll tell you, many times you get patients complaining of this. We were not aware of these. You, in your training, should learn these, and then you can make an accurate diagnosis. Many patients who come to us with growing pain, we search for hernias. This is not so. You have to search for other conditions, like tears of the labrum, like avulsions. Keep this in mind. It is interesting that you know these. It is not uncommon to feel pain laterally or posterior with anterior labral tears. So you have to build a differential diagnosis in your mind as you are examining the patients. Pain with prolonged sitting is another common symptom. Physical examination findings can include pain in the provocative position of flexion, adduction, and internal rotation. If the tear is anterior, or pain in flexion, abduction, and external rotation if the tear is lateral. Okay? So you have to know these. You have to study it. It's not much for you to remember. Look at the labrum, look at its position, look at its triangular shape, and then put in your mind the various functions of the labrum for stability. Then put in your mind the labrum in association with femoral acetabular impingement. Then put in your mind comparing it to a meniscus. Where is the tear? Is it at the junction of it and the hyaline cartilage? Is it multiple tears within the labrum? This is not much to remember. You can really remember these. And you have to know on physical examination the findings that include the pain. You have to provoke the pain by doing flexion, adduction, and internal rotation. This would tell you whether if the patient has pain, it would tell you whether it is anterior. What are you doing? You are flexing, you are adducting, you are internal rotation. you are irritating the anterior portion. Or if the pain is present in flexion, abduction, and external rotation, then it will tell you the tear is lateral. This is not much to remember. So you have to know about the different types of tears. Let me go through this slide because I felt it was important. If you have an anterior tear, you have a flexion, abduction, and internal rotation positive test, meaning that it is known as the Fadir test, in opposition to the Faber test, flexion, abduction, and external rotation. You have to know that the Fadir test would tell you that there is an anterior labral tear. You can dynamic internal rotation and impingement test. The lateral tears, flexion, abduction, and external rotation. This is the Faber test, and this is a dynamic external rotation impingement test. Hip instability, extension, and external rotation. External rotation log roll test. And then comes the ligamentum teres test, which we will be discussing. In the past, we thought that the ligamentum teres was insignificant. We thought even that the blood that comes through it was insignificant. But now you see how significant it is. So these are the tests that you should know. Imaging includes plain radiographs and magnetic resonance arthrography. The most valuable diagnostic sign is a positive response to an intra-articular joint injection that brings complete pain relief, even for a brief period. This assessment is especially helpful in patients with atypical referred pain, locations to confirm the joint as the source of pain. Treatment options for labral tears include debridement, repair, and reconstruction with the goal of restoring or preserving the function of the native labrum. Debridement is reserved for tear patterns that are stable and in which the function of the labrum will be maintained. Repair is appropriate for unstable tear patterns in which excision would render the labrum incompetent. Several studies have shown improved results with repair versus debridement in groups treated with an open surgical hip dislocation as well as in arthroscopic repair. A comparison of labral debridement versus repair in open surgical hip dislocation for femoral acetabular impingement showed substantial improvement in clinical outcomes, with 80% excellent results in the labral repair group versus 23% excellent results in the debridement group. Radiographic signs of osteoarthritis were significantly more prevalent in the debridement group at final follow-up. Furthermore, superior clinical outcomes and patient satisfaction were seen with arthroscopic labral repair versus labral debridement, with 67% good or excellent results in the debridement group versus 90% in the repair group. Labral repair and debridement were compared in a randomized controlled trial, and significantly greater improvement in the hip outcome score in the repair group was found, although both groups demonstrated improvement from preoperative states. In addition, 72% of the patients in the repair arm self-rated their hips as normal versus 23% in the debridement arm. So, in other words, repairing the labrum gave significantly better results than removal or excision or debridement of the labrum. Labral reconstruction traditionally has been reserved for revision cases in which the primary labral repair has failed. Reconstruction may be considered in young athletes with an irreparable tear or hypoplastic labrum that renders the labrum incompetent, especially in a high-demand sport that requires cutting and pivoting at high speed or repetitive rotational maneuvers, or for patients at risk of instability. Good outcomes and high patient satisfaction were seen with labral reconstruction using iliotibial band autografts. Better results occurred in younger patients with no joint space narrowing less than 2 millimeters. Hip instability. Hip instability has been increasingly recognized as a pathologic entity and a source of chronic pain and disability over the past decade, especially in cases of more subtle atraumatic instability. Unlike those in the shoulder, the major stabilizers in the hip are the static restraints and include both osseous and soft tissue structures. The osseous components consist of highly constrained femoral head inside the concentric acetabulum. The degree of acetabular coverage, the femoral and acetabular version, are key determinants of stability. It is in the setting of diminished acetabular coverage and alterations in normal version that the hip joint increasingly relies on soft tissue structures to maintain stability. The soft tissue static restraints include the labrum, the capsule, and the ligaments. The labrum is a triangular fibrocartilaginous ring encompassing the acetabulum at all but its most inferior aspect, which is spanned by the transverse acetabular ligament. The labrum deepens the acetabulum. It increases the coverage of the femoral head and enables the joint to have a negative suction seal, just as occurs in the shoulder, which increases stability. This shows you the labrum. It shows you the ligamentum teres. The labrum deepens deepens the acetabulum. The labrum creates a negative pressure to hold the hip within the joint, the head within the joint, within the acetabulum. Keep this in mind. It is triangular in shape, it deepens, and it increases stability. These three primary ligaments span the joint and blend the capsule. These are shown in Table 3 we will be discussing. The strongest is the iliofemoral ligament, which is an inverted Y-shaped ligament that originates just inferior to the anterior inferior iliac spine and attaches distally along the femoral intertrochanteric line. This shows you the various ligaments. You see the iliofemoral ligament, of how it originates just above the acetabulum and inserts on the intertrochanteric line, and it consists of two bands. And you have a pubofemoral ligament. You have the head, which lies within the acetabulum. Also, don't forget about the ischiofemoral ligament. So you have also the orbicular zone, which is the capsule, which becomes like a ring around the base of the capsule that gives you further strength. So you have to know these ligaments. You have to know its relation to the rectus femoris tendon. You have to know that the iliofemoral ligament is just inferior to the rectus femoris tendon. You have to know about the pubofemoral ligament. You have to know about the ischiofemoral ligament. Also the orbicular ligament, which forms a kink at the base of the capsule. This shows you the iliofemoral ligament arising from the anterior inferior iliac spine, inserting on the intertrochanteric line. You have to know about the pubofemoral band. You have to know about the iliofemoral band and the anterior inferior, and that's it. So this would tell you more about what are the structures that stabilize the hip. So the hip ligaments and their motion restrictions. The iliofemoral ligament restricts extension and external rotation. The ischiofemoral ligament restricts flexion and internal rotation, and at times extension and internal rotation. The pubofemoral ligament restricts abduction and external rotation, and the ligamentum teres restricts flexion and external rotation, and extension and internal rotation. These ligaments stabilize the hip. They stabilize it in association with the labrum. And of course, one should not forget about the bony buildup, which stabilizes it. These are static stabilizers. The inferior the iliofemoral ligament has been shown to limit hip extension and external rotation. The pubofemoral ligament is inferior to the iliofemoral ligament, originates on the pubis, and blends in with the iliofemoral ligament. At its medial attachment, extending along the femoral intertrochanteric line. So you have the PFL, pubofemoral ligament, the IFL, the iliofemoral ligament. They blend together on to the intertrochanteric line. These all give us stability. The pubofemoral ligament has been shown to limit external rotation and abduction. The ischiofemoral ligament is located posteriorly, connecting the posterior acetabulum to a portion of the posterior femoral neck. The ischiofemoral ligament provides some support to the posterior femoral neck because of their helical orientation. The three ligaments twist when they are taut and are thought to provide a screw-home mechanism to the joint when the hip is extended. The zona orbicularis is a circumferential structure that forms at the collar around the base of the femoral neck and is thought to resist distraction. Please put the three ligaments together: the iliofemoral, the pubofemoral ligament, the ischiofemoral ligament, and the zona orbicularis. All three ligaments restrict motion in particular directions, but they increase stability of the hip joint. The ligamentum teres appears to play a secondary role to these soft tissue restraints, having been shown to restrict the motion of the femoral head. Furthermore, isolated tears of the ligamentum teres have been found in hip dysplasia, in which it may play a more prominent role in stabilization. Hip instability is thought to have traumatic and atraumatic origins, as is shown in the table to come. Traumatic origins include high energy and low energy mechanisms. High energy mechanisms can lead to osseous disruptions and an unstable hip joint, as in hello. As in, continue. As in, am I clear, by the way?
Yeah, it's very clear, doctor.
Okay. High energy mechanisms can lead to osseous disruptions and in unstable hip joint, as in posterior acetabular rim fractures. What are the risk factors for hip instability? We all know that acetabular dysplasia is a factor and a cause of instability. Abnormal femoral and acetabular version. Is it antivertic? Is it retroverted? Is it neutral? All these are factors that could affect stability. Generalized ligamentous laxity, as in Marfan syndrome, or Mongolism. All these are present, and they can give us instability. Iatrogenic capsular insufficiency and sports requiring extreme hip motion. All these lead to hip instability. The hip ligaments and motion restrictions we spoke about. Risk factors for instability are shown well here. I want to show you this patient who has had a tear. Let me read it, it's better. Images depict assessment of the iliofemoral ligament. In A, on the extreme left, is a coronal magnetic resonance arthrogram demonstrates a large capsular defect after hip arthroscopy. You can see it over here. The photograph in B shows an external rotational log roll test for iliofemoral ligament instability. The examiner externally rotates the leg at the foot. A normal ligament would display spring back. In C is a photograph which shows capsular plication of the left leg within endpoint of the external rotation, whereas the right leg shows preoperative iliofemoral ligament instability. You can see it in C, the right side, you have complete ligamentous instability. There's no spring back to external rotation. Don't forget this. A, you have a tear secondary to arthroscopy. You have a huge amount of tear and instability. You have to pay attention to these. The classic example is the motor vehicle accident in which the knee strikes the dashboard, resulting in a posterior hip dislocation. High energy mechanisms also can lead to disruptions of the soft tissue, such as labral tears and ligament sprains, resulting in instability in the absence of a fracture. So you have to pay attention. Sports with repetitive torsional movements can produce soft tissue attenuation due to repetitive microtrauma to the capsule and ligaments. A common example is the athlete engaged in a sport requiring extreme amounts of hip motion and rotation, such as gymnastics, ballet, and golf. Atraumatic origins also can be seen in patients with congenital soft tissue deficiency or laxity, such as the capsular and ligamentous laxity seen in Ehlers-Danlos syndrome, Marfan syndrome, and Down syndrome. The atraumatic mechanism most recently described is a sequela of a large cam-based deformity in femoral acetabular impingement. In this case, impingement of the cam lesion inside the acetabulum inflection leaves the femoral head posteriorly, which can cause a posterior countercoup cartilage lesion with posterior subluxation and instability. The concept of atraumatic hip instability has led to the emerging idea of hip microinstability. This type of instability can occur in athletes with mild osseous hip dysplasia superimposed on ligamentous laxity during sports requiring high degrees of hip motion. If you take the ligaments, if you take the labrum, if you take the various structures around the hip, the ligaments, all could lead to instability due to repeated stretching, to trauma, to defects, due to congenital problems also, and due to conditions like Ehlers-Danlos syndrome or Marfan syndrome or Mongolism. All these have ligamentous laxity and instability of the hip. In the setting of hip dysplasia, the individual is much more reliant on soft tissue structures to stabilize the hip. The athlete with hip microinstability may report mechanical symptoms and feelings of instability, especially in hip positions that rely more on soft tissue restraint, like hip extension and external rotation. These patients tend to be highly symptomatic and pain and can have difficulty with tasks as simple as walking. Secondary iliopsoas tendinitis resulting from strain on the iliopsoas as it attempts to stabilize the anterior hip joint can develop in these patients. On examination, these patients may show global signs of generalized ligamentous laxity. The log roll external rotation test may show a capsular laxity with diminished spring back during external rotation. The results of this test can be compared with those of contralateral hip. These patients also may have pain and apprehension during hip extension and external rotation if the primary component of instability is anterior. This pain and apprehension can be improved with a posteriorly directed force to the proximal femur in the position of anterior instability with external rotation and extension, a maneuver comparable to the Job relocation test in the shoulder. Okay, keep this in mind. Patients with hip microinstability in whom non-surgical treatment has failed may benefit from a hip arthroscopy to address ligamentous and capsular laxity as well as labral tears. The labrum can be repaired after addressing any associated rim pathology using a mattress suture which will restore the suction seal. Several procedures have been described to address the capsule in instability, including thermal capsulorrhaphy and capsular plication. Thermal capsulorrhaphy was described in 95 patients having a monopolar radiofrequency probe to reduce the capsular redundancy with resolution of hip instability in 100% of his patients at 12 months and improvement in their modified Harris hip scores. To date, no reports have been recorded of chondrolysis secondary to thermal capsulorrhaphy in the hip, as has been described in the shoulder. Capsular plication also has been described by several authors as a method to reduce capsular redundancy. A technique has been described in which the medial and lateral limbs of the iliofemoral ligament were tied together to reduce capsular laxity. Another technique in which the capsule is plicated by including it in a labral repair using double loaded suture anchors at the acetabular rim has been described. This second technique is thought to restore normal anatomy and appropriately tension the capsule with good short-term results The evolution of the concepts of capsular laxity as a source of hip instability has led some authors to stress the importance of capsular management and the recognition of risk factors for instability in hip arthroscopy performed to address other pathology. This concept has been reinforced by recent case reports of hip dislocations following hip arthroscopy. The authors of one study reported hip subluxation in a patient with a dysplastic hip 3 months following an arthroscopic labral resection and capsulotomy. A case of a traumatic anterior hip dislocation was reported in a post-operative patient following a fall downstairs that was successfully treated with a revision capsular repair. The authors of another study reported a high dislocation in the recovery room in a patient who had undergone an arthroscopic capsulotomy for a cam resection and rim trimming. The dislocation was successfully treated with mini-open anterior capsular raphe. Recently improved outcomes have been demonstrated in patients undergoing hip arthroscopy with a complete capsular repair versus a matched cohort that underwent a partial repair only. The complete repair group demonstrated superior sport specific outcomes and had a 0% revision rate compared with a 13% arthroscopic revision rate in the partial repair group. Current recommendations for capsular management involve performing an interportal capsulotomy between the standard anterior and the anterolateral portals to address central compartment pathology. This procedure is followed by adding a longitudinal capsulotomy to form a T-capsulotomy down the neck of the femur. In the interval between the capsulolaris and the gluteus medius and the gluteus minimus. I'm sorry, I'm putting water to drink. This procedure is followed by adding a longitudinal capsulotomy to form a T-capsulotomy down the neck of the femur in the interval between the iliocapsularis and the gluteus minimus. This longitudinal component placed just proximal to the zona orbicularis to protect the lateral femoral circumflex artery. This exposure typically allows ample visualization of a cam lesion. Hip rotation provides visualization from the medial to lateral synovial folds, which are landmarks for the synovial vessel. Both limbs of the T-capsulotomy are repaired at the completion of the case with several side-to-side sutures. The capsule can be plicated at this stage if indicated by resecting a portion of the capsule before repair or by taking bigger bites on the side-to-side closure to tighten the capsule. By tightening the capsule, we are stabilizing the hip joint. In general, 3 or 4 sutures are used on the longitudinal portion and 2 or 3 sutures are used on the interportal portion. The patient is placed in a brace for 6 weeks, post-operatively to limit extension and external rotation, with a period of protected weight bearing as indicated for other procedures. Now we come to something which is very interesting, the ligamentum teres. We all thought it was something benign and did not deserve discussion. Now, ligamentum teres can be a common source of hip pain and has been found to be torn at arthroscopy in 8 to 51% of cases. Pay attention, 8 to 51%. It was found to be torn. It is a pyramid-shaped structure with its broad base at the posterior-inferior acetabular fossa and its point attaching to the femoral fovea capitis. So it is pyramidal shape, inserting onto the head. This shows it. You see, it's like a pyramid, and it becomes narrower as it inserts into the fovea within the head. It forms some attachment to the transverse acetabular ligament at its base and transitions to a round and ovoid attachment to the femur. It has been shown to contain free nerve fibers or endings with both nociceptive and proprioceptive innervation concentrated primarily in the center of the ligament, confirming its role as a potential pain generator in the hip. The function and pathologic role of the ligamentum teres remains controversial. Currently, it is thought to serve as a secondary restraint to hip stability. The first suggestion that the ligamentum teres might play a role in hip stability surfaced in an early cadaver study demonstrating that sectioning the ligamentum teres resulted in increasing amounts of abduction and adduction. So when you section the ligamentum teres, you increase hip abduction or adduction, and this was proven in cadavers. A string model was used to assess the ligamentum teres excursion during hip motions and showed the greatest excursion during hip external rotation and flexion, which occurs in squatting and during internal rotation and extension, which occurs when crossing one leg under the other. The ligamentum teres moved into an anterior and inferior position around the femoral head during a squat. This was thought to provide a sling-like effect analogous to the actions of the conjoint tendon in the coracoid transfer procedure in the shoulder. In a survey of 161 post-operative patients who had undergone a surgical hip dislocation, which includes resection of the ligamentum teres, it was reported that 35% of patients described popping and locking, and 24% experienced feelings of instability. So you should keep in mind that the ligamentum teres is involved in stability of the hip joint in association with other structures. Ligamentum teres may play a more important role in stability in dysplastic patients lacking acetabular coverage. These patients may be more reliant on primary soft tissue restraints, such as the labrum, the capsule, and ligaments. If one or more of these soft tissue restraints also is compromised, increased reliance on the ligamentum teres to maintain a concentric hip joint may occur with certain motions. Injury to the ligamentum teres is thought to occur from one of several mechanisms. The ligamentum teres is at risk with any major hip trauma causing a hip dislocation. It has been torn with lower levels of trauma, however, including a case report of a tear occurring while the patient pushed a shopping cart. Ligamentum teres tears also can occur from repetitive microtrauma in sports, requiring extreme amounts of hip motion, such as dance, gymnastics, and martial arts. Microtrauma to the ligamentum teres may be exacerbated in patients with ligamentous laxity or insufficiency, in which the ligamentum teres is thought to play a larger role in instability. Finally, a degenerative tear can occur due to abrasive wear against osteophytes in osteoarthritis. The clinical assessment of ligamentum teres tears traditionally has been difficult. Patients may report an injury during a twisting mechanism, a fall onto a flexed knee, or a hyperadduction mechanism. Patient reports may include pain, mechanical symptoms, and feelings of instability and giving way, especially during squatting and when crossing the affected leg behind the other when standing. Some patients may present with pain as their only symptom. So you can see how important the ligamentum teres is. Physical examination findings in patients with ligamentum teres are consistent with findings in other tests for intra-articular pathology. These non-specific tests include pain with flexion and internal rotation, log rolling and extension, and during the McCarthy test, in which the hip is alternatively taken from flexion to extension in the internal rotation and then external rotation. A test collected called the ligamentum teres test was recently described that may aid the diagnosis. What is this test? It is performed by placing the patient supine, flexing in the hip to 70 degrees, flexion of the hip, abducting it 30 degrees, and rotating into maximum internal and external rotation. This test was found to have a sensitivity of 90% and a specificity of 85%. Imaging to identify the ligamentum teres pathology also has proven difficult traditionally. The authors of one study noted that only 2 of 23 ligamentum teres tears in their series were diagnosed preoperatively. In an attempt to distinguish partial ligamentum teres tears from normal anatomy, the authors of a 2012 study found similar radiographic findings on 3 Tesla magnetic resonance arthrography between the partial tear and normal anatomy. Their ability to diagnose ligamentum teres tears ranged from 42 to 67%. Finally, a sensitivity of 34% and a specificity of 53% in identifying pathology in the ligamentum teres was found, also using a 3 Tesla MRI. Treatment options for ligamentum teres include debridement and reconstruction. A systematic review of compared the short-term benefit of 2 modalities. So this compared the short-term benefit. The 6-patient reconstruction group was compared with 81 patients in the debridement group. Although having very small numbers, the reconstruction group showed improved subjective and objective outcomes scores despite using different graft sources and fixation techniques. The indications for repair versus reconstruction are not yet defined clearly. In summary, hip arthroscopy continues to evolve rapidly along with the understanding of pathology and in and around the hip joint. You have to know the anatomy well. You have to know the pathology well to do arthroscopy, and you have to know the complications well. The indications for surgery include pathology in the central, peripheral, and peritrochanteric compartments, and the indications are expanding to include pathology in the surrounding soft tissues. The acetabular labrum is a critical structure and should be repaired or reconstructed whenever possible to preserve its function, especially the negative suction seal function. Hip instability has proven to be a source of chronic pain and disability. Soft tissue structures, including the ligamentum teres, play a key role in maintaining stability, especially in the setting of abnormal bony morphology. Appropriate capsular management, including capsular repair and plication in indicated cases, is proving to be a key step in preserving or establishing hip stability and optimizing surgical outcomes. Tears of the ligamentum teres are a source of pain in the hip and require a high index of suspicion to make the diagnosis. The ligamentum teres test is a new physical examination tool to aid in making the diagnosis. Debridement of partial thickness tears has demonstrated good clinical outcomes. Ligamentum teres reconstruction in instability cases may prove to be a useful adjunct along with capsular plication in certain settings, but is still unproved at this point. What are the key study points? Acetabular tears are the most commonly noted pathology at hip arthroscopy and should be repaired or reconstructed whenever possible to restore labral function of creating a negative pressure seal to the femoral head. Hip microinstability is an increasingly recognized source of pain and instability because of soft tissue restraint incompetency in the borderline dysplastic hip. The acetabular labrum, the ligamentum teres, and the joint capsule play critical secondary roles to bony restraint. Tears of the ligamentum teres can be an important source of pain and disability, which require a high index of suspicion to diagnose, but are successfully treated with surgical debridement and reconstruction. Hip and groin injuries are common problems that can lead to disability in athletes. The clinical and diagnostic presentation of various potential entities can overlap, making diagnosis and treatment difficult. Last part of our conference today is also very important. And many people ask me about the symphysis pubis. When you see that it is irregular, what should we do? And this is what we get quite often in athletic pubalgia, core muscle injury, and groin pathology. This is the last topic we will be discussing today, and I think it's the most interesting topic. Now, when you get a pubalgia, it is a challenge and it can lead to time lost from athletic participation and subsequent frustration for athletes with these conditions. And this is one of the conditions that is disturbing. You see, in a young individual, one symphysis, portion of the symphysis is higher than the other. You see that there is a gap. You see that one is totally irregular, plus muscle abnormality, plus ligament abnormalities, plus intra-articular structures like the labrum and ligamentum teres. All these affect the hip. So you have to keep in mind. Now, what is the differential diagnosis for activity-related groin pain? And this has been described in broad categories as core muscle injury, athletic pubalgia or sports hernia, hip joint pathology, intra-articular pathology, and other etiologies. The anatomic structures of the hip and pelvis have been described based on layers. Layer 1 consists of osseous morphology, including the pelvic bones and acetabulum and proximal femur. Layer 2 consists of soft tissue in and around the hip that we have discussed, including the labrum, the capsule, ligaments, which had substantial stability to the hip. Layer 3, it consists of contractile layer around the hip, including the adductors, the abductors, the flexors, the extensors, and internal and external rotators of the hip. And finally, layer 4 consists of the neurovascular structures that surround the hip. The main components of this layer are the lateral femoral cutaneous nerve, the obturator nerve, the inguinal nerve, the sciatic nerve, and the genitofemoral nerve. It should be noted that all of these structures can be sources of pain when evaluating patients with lower abdominal hip groin pain. In addition, patients with extra-articular hip pathology can have concomitant femoroacetabular impingement or intra-articular hip pathology. What do we mean by athletic pubalgia? What about the pathoanatomy? The anterior bony pelvis with its main muscle attachments and pubic symphysis forms the center of core injuries and sports hernia. The abdominal wall musculature also has been described in layers. The layers from superficial to deep are the fascia, the external oblique fascia and muscle, internal oblique fascia and muscle and transversus, abdominis muscle and transversalis fascia. This is a slide which shows you these various muscles layers. A portion of them attach on the pelvis. And now we will see what is happening. The rectus abdominis muscle, conjoint tendon, the internal oblique and transversus abdominis fascia, and the external oblique muscle merge to form the pubic aponeurosis, which inserts onto the pubic tubercle. Don't forget this. The medial thigh compartment consists of the pectineus, the gracilis, and the adductor brevis, longus, and magnus muscles. The ligamentous complex at the pubic symphysis consists of the anterior, superior, posterior, and arcuate ligaments. The superior and arcuate ligaments are the main stabilizers of the pubic symphysis. Let us speak about what is happening. If you look at the rectus abdominis, and if you look at down the lower end, the adductor longus. These, one attaches distally, the other one attaches proximally. And if one goes, then you will end up with an imbalance. If the rectus abdominis is torn or lost to function, likewise, the whole pelvis would move distally at the symphysis pubis, and vice versa. So you have to pay attention to this. The pubic symphysis is the center of various forces generated at the anterior pelvis. Athletic pubalgia is defined as an injury to one of the previously described structures as it inserts into the pubis without the presence of a clinically recognizable hernia. So the term sports hernia is a misnomer. خليني أقول لكم كم مريض بيجي عندكم and we start thinking, does this patient have a hernia? We send him to the general surgeon. The general surgeon does not find a hernia, and then this patient roams around from one doctor to another, not knowing what he has. Well, let me tell you, these are micro tears in the muscle, and as a result, we have an imbalance, and therefore these patients would have pain as though they have a hernia, but it's a pure tear. You have to keep this in mind. Injury to or deconditioning of one of the anterior pelvic structures can result in increased stress and strain on the adjacent structures. This can lead to complete disruption of one of the musculotendinous origin, insertions or ligaments about the pelvis. What about the clinical presentation? Rapid lateral motion, acceleration, deceleration, hyperextension or hyperabduction can lead to increased tension in the pubic region. Athletic pubalgia is seen primarily in athletes who are involved in cutting and pivoting activities. In one study, 31% of patients who presented with athletic pubalgia were athletes. Patients typically present with exertional pain during activity without a specific injury or even event causing the pain. Anterior groin or lower abdominal pain is brought on by physical activity and is usually relieved with rest. The lower abdominal or groin pain often resumes with activity after a period of rest. Occasionally, pain can radiate proximally into the abdominal musculature or distally into the thigh, groin region, or scrotum. Physical examination should begin with palpation of the pubic symphysis, the rectus abdominis muscle. The internal and external oblique muscles should be investigated. The origin of the adductor muscles, the pectineus and gracilis muscles, and the inguinal ring for areas of tenderness. You should examine them. You should palpate the whole area. Don't tell them they have a hernia. The lower abdominal pain or groin pain pain that is worse with sport-specific activities, including kicking, cutting, sit-ups, and sprinting, and that is relieved with rest, tenderness, to palpation over the pubic ramus, pain with resisted hip adduction, and pain with resisted abdominal sit-ups are the 5 most common complaints or findings in patients with athletic pubalgia. Evaluation of potential intra-articular hip pathology using the Fadir flexion, adduction, and internal rotation test should be performed because concomitant hip joint pathology is not uncommon, and intra-articular and extra-articular hip and pelvis disorders often are related and compensatory in nature. What about imaging? Initial imaging begins with a well-centered anterior-posterior view of the pelvis and lateral hip radiographs. These images are usually negative in patients with isolated athletic pubalgia, but are used to rule out avulsion injuries about the pelvis, radiographic signs of bony impingement, stress fractures, osteitis pubis, sacralized lumbar vertebrae, and other potential sources of pain. MRI is the current standard for evaluation of activity-related pelvic pain. A dedicated athletic pubalgia MRI protocol, including large field of view and small field of view images, focusing on the pubic symphysis, is useful for accurate diagnosis and location of the pathology. MRI is 68% sensitive and 100% specific for rectus abdominis pathology compared with findings at surgery, and is 86% sensitive and 89% specific for adductor pathology. It also is 100% sensitive for osteitis symphysis pubis. MRI should be reviewed closely for osteitis pubis, rectus abdominis strain, adductor tendon injury, rectus abdominis or adductor epineuritic injury or plate disruption, inguinal hernias, femoral stress fractures, and hip joint related pathology. The most frequent finding on MRI is fluid signal extending from the anterior inferior insertion of the rectus abdominis into the adductor origin with corresponding fluid signal in the pubis. You see this, you can feel it, you can look at it and imagine. This is an MRI of the hip and pelvis of a 22-year-old football player with left-sided lower abdominal and proximal adductor related pain, reveals a disruption of the distal rectal abdominis and adductor epineuritis on the left side. Look at the white arrow, it's pointing to the area. It's not a hernia, it's a tear, it's a rupture. What about diagnostic injections? As described previously, several potential pain generators are present about the pelvis and groin. Diagnostic injections can help determine the etiology of pain when conflicting results appear on clinical examination. Administering an intra-articular injection of local anesthetic into the hip joint can be useful before having the athlete perform activities that typically provoke pain, or re-examining the patient in the office. So you inject the patient, you see the patient. Has the pain subsided or not? This will help in the diagnosis. Persistent pain in the groin or lower abdominal region after intra-articular injection can be consistent with concomitant or isolated athletic pubalgia. Anesthetic injections into the pubic symphysis, adductor cleft, or psoas bursa also can aid in the diagnosis. Treatment, non-surgical treatment. Relative rest and avoidance of activities that provoke pain comprise the initial treatment. Physical therapy should focus on core strengthening as well as identifying areas of weakness or reduced range of motion. Therapy should focus on resolving imbalances between the pelvic and hip stabilizers. Non-steroidal anti-inflammatory drugs and ice can be used to minimize swelling and pain during the rehabilitation period. Patients generally are treated for at least 3 months with activity modification and physical therapy. If substantial improvement is achieved, non-surgical treatment is continued with a gradual sport-specific activity progression. If no improvement is seen between 3 months, surgery might be considered. Ultimately, the duration of non-surgical treatment and the timing of potential surgery are variable, depending on the level of the athlete and the schedule of the sports season. Surgical treatment. Various surgical procedures have been described for the treatment of athletic pubalgia, plication of the transversalis fascia, reapproximation of the conjoint tendon to the inguinal ligament, and approximation of the external oblique aponeurosis has been described. Patients had a return to sport rate of 95% at 12 weeks. An open approach for the treatment of athletic pubalgia has been described with reattachment of the anterior inferior rectus abdominis with an adductor release. 152 of 157 patients with athletic pubalgia who underwent primary pelvic floor repair were able to return to their pre-injury level of competition. In a study examining results over 20 years, 95% of athletes were able to return to sports participation at 3 months post-operatively. An open repair technique using mesh has been studied. All patients underwent bilateral mesh repairs with the mesh bridging from the pubis to the anterior superior iliac spine. The peritoneum was closed over the mesh, and it was reported that all patients were able to return to full sports participation post-operatively. Multiple authors have published their experience with laparoscopic repair. A recent randomized controlled trial compared patients with athletic pubalgia treated with a laparoscopic mesh technique with those who underwent non-surgical treatment. At 3 months, 90% of laparoscopic group returned to sport compared with 27% of non-surgical group. At 12 months, 97% of the surgical group had returned to sport compared with 50% of the non-surgical group. It is recommended that patients with suspected athletic pubalgia be referred to an experienced general surgeon with an interest in groin pathology. There is little evidence to suggest that one repair technique is superior to another based on the current published literature. Complications. The most common post-operative complication is edema in the abdomen, thighs and genitals, and perineum. Wound infection is reported at 0.4%, and the hematoma requiring reoperation has a rate of 0.3%. Nerve dysesthesia has less than 1% occurrence rate and usually affects the various anterior located nerves, namely the anterior, lateral, femoral, cutaneous nerve distribution. Sorry, all this should be in one line. The ilioinguinal nerve or the genitofemoral nerve. So these are the nerves that are affected, the anterior group of nerves, the anterior lateral femoral cutaneous nerve distribution, the ilioinguinal or the genitofemoral nerve. This occurs in 1%. Penile vein thrombosis is reported in the literature, but all cases resolve. The most common reason for reoperation is the development of athletic pubalgia on the contralateral side. The second most common reason for reoperation is inadequate adductor release or repair at the time of the athletic pubalgia repair. Failure to address intra-articular pathology is another reason for continued disability after repair. Rehabilitation. Most recent studies have reported a return to full activity 1 to 6 months after surgery, depending on the type of repair. Patients may bear weight as tolerated post-operatively with physical therapy starting at 1 to 14 days post-operatively. Physical therapy initially focuses on abdominal and adductor flexibility and targeted abdominal strengthening. Sorry, this is not abdominal, it's abdominal. A stepwise running program begins at 4 weeks after surgery with sport-specific exercises starting at week 5. Activity as tolerated is allowed around 6 weeks post-operatively. Now, this is a very important topic for you because you can have combination of problems that can give you pain. Pubalgia and femoral acetabular impingement. Overlap between intra-articular and extra-articular pathology often occurs in patients presenting with lower abdominal, groin, or hip pain. Recently, using a cadaver model, it has been shown that patients with femoral acetabular impingement have increased stress placed on the pubic symphysis, which may predispose to combined femoral acetabular impingement and athletic pubalgia. In other words, if you have a CAM, the CAM can not only result in hip osteoarthritis, but it can be associated due to overstress of certain muscles on another muscle, which is acting in the opposite direction, which has led to athletic pubalgia. So keep in mind that you can have a combination of these two conditions. It is imperative to determine the source of pain so that proper expectations and treatment options can be presented. A subset of patients will present with combined femoral acetabular impingement and athletic pubalgia. Clinical examination and detailed imaging can help to determine the combined diagnosis. This is an AP of the pelvis and a done lateral radiograph from a 23-year-old man, which show combined femoral acetabular impingement and athletic pubalgia. Often, it is difficult to determine how much pain or disability results from each entity. In these cases, anesthetic intra-articular and extra-articular injections can aid in the diagnosis. When it is determined through a detailed examination, imaging, and possibly diagnostic injections that a combined process is occurring, treatment can be tailored for both entities. Treatment of only one of the pathologies can lead to suboptimal results. In a study of patients with combined femoral acetabular impingement and athletic pubalgia, patients who had athletic pubalgia surgery alone returned to their previous level of sport participation in 25% of the time. Of patients who underwent arthroscopy for femoral acetabular impingement, only 50% returned to the previous level. You have to combine the two to have a good result. Of patients who had both athletic pubalgia surgery and hip arthroscopy, 85% to 91% returned to sport. No difference was seen whether surgery was performed in a staged fashion or if both treatments were performed at the same time. Adductor strain and pathoanatomy. Myotendinous injuries and strains are more common when the muscle crosses two joints, and they usually result from eccentric contraction. The injury usually occurs at the myotendinous junction. Adductor injuries often occur at the origin in the pelvis. However, it may be caused by a different mechanism than typical muscle strains. Adductor strains are common in athletes who participate in pivoting and cutting activities and kitting and saucers. So you have to look at, let's look at this slide. Illustration showing injury to the abdominal, wall at the facial attachments of the rectus and adductus onto the pubis, which is implicated in athletic pubalgia. The two arrows show the opposing forces that are placed on the pubis, secondary to the rectus and adductus. So these opposing forces, if one is injured, the other will act abnormally and behave either due to overactivity leading to a pubalgia, as we are talking about. So you have to pay attention to this. The adductor group works in conjunction with the abdominal musculature to stabilize the pelvis during walking and running. The adductor longus origin on the pelvis may predispose the adductor longus origin on the pelvis may be predisposed to injury because of its small cross-sectional area compared with the size of the muscle belly. In other etiology for adductor strain is, sorry, Andy, block on it. Let me see if I can solve it. Yeah, I solved it. Good. Another etiology for adductor strain is a muscle imbalance between the abductors and the adductors. And it has been reported that professional hockey players are 17 times more likely to incur an adductor strain if their adductor strength was less than 80% of their abductor strength. In a follow-up study, the authors showed a significant reduction in adductor strains in a similar population when a preventive adductor strengthening program was instituted. What about the clinical presentation? Adductor strains are common in athletes participating in football, soccer, hockey, and dance. These athletes often present with acute medial groin or proximal thigh pain. Adductor strains are usually self-limiting, requiring minimal treatment with very high rates of return to play. Chronic proximal adductor pain related to sports participation can be associated with athletic pubalgia or hip impingement, such as femoroacetabular impingement. One study of athletes with proximal adductor pain reported underlying femoral acetabular impingement in 94% of athletes based on radiographs. On examination, tenderness to palpation is present over the adductor longus tendon. Patients experience pain with passive abduction, and palpable defects sometimes will be present. Patients also have pain with resisted adduction. When evaluating patients with adductor injury, it is important to assess for athletic pubalgia and femoroacetabular impingement. What about imaging? Imaging for adductor strains is usually not indicated because many of these injuries are self-limiting. For patients experiencing chronic disability secondary to a groin injury, or in patients with a palpable defect, imaging may be warranted. A well-scented AP pelvis radiograph should be obtained with initial evaluation for apophyseal avulsions, osteitis pubis, pelvic stress fractures, or intra-articular findings that may explain continued disability. MRI is the next study for evaluation of musculotendinous injury, injury at the insertion site, and intra-articular hip pathology. MRI sequences that have been described for the evaluation of athletic pubalgia are indicated. Muscle strains with cross-sectional area involvement greater than 50% on MRI, fluid collections, and muscle tears are associated for longer recovery times. Adductor longus tears with a palpable defect usually show a 3 centimeter or greater retraction of tendon on MRI. These show you a adductor avulsion over here. You can see it compared to the intact tendon over here. The adductors. Over here it's avulsed. You have an increased signal intensity. Treatment. Activity modification, ice, compressing, non-steroidal anti-inflammatory drugs, and gentle range of motion exercises are the mainstay of initial treatment after adductor tendon injury. When pain decreases, formal physical therapy can begin using a variety of modalities, including static stretching, massage, tissue mobilizations, and proprioceptive neuromuscular facilitation. Cryotherapy may be helpful for reduction of swelling and pain relief. Electrical stimulation may be used to prevent muscle atrophy. External wraps can limit the amount of active and passive hip abduction and can provide comfort in the acute setting. When pain is manageable, gentle range of motion exercises can begin, including exercise, bike riding, and pool exercises. After full range of motion is achieved, a strengthening program is instituted, focusing on core strengthening, polymetric, and gentle running straight ahead. The patient's activities are gradually advanced with sport-specific drills. Patients are able to return to play after full strength and pain. Free motion are achieved with a mean return to play of 6 weeks. For patients in whom non-surgical treatment has failed, injections may be warranted. Platelet-rich plasma, corticosteroid, and simple anesthetic injections have been described for adductor strains. Injections into the adductor incisors have shown some success in competitive and recreational athletes. If non-surgical treatment of 3 to 6 months has failed, surgical treatment may be considered. In a case series of 16 competitive athletes with chronic isolated adductor pathology, non-surgical measurements, including rest, physical therapy, and non-steroidal anti-inflammatory corticosteroids, failed in all patients. Surgical treatment consisted of open tenotomy 1 centimeter from the adductor longus origin. All patients improved and were able to return to sports activities. At final follow-up, 10 of 16 patients were pain-free. Adduction strength was weaker after full recovery. A fractional lengthening 3 centimeters distal to the origin to minimize post-operative weakness. Caution should be exercised when considering a release in saucer strikers, because this procedure might lead to detrimental adductor weakness. In 2009, study of 19 national football players who sustained a rupture of the adductor longus, 14 were treated non-surgically, 9 underwent surgical repair. The non-surgical group returned to play at 6 weeks, compared with 12 weeks in the surgical group. No strength deficits were present in either group. Of the surgical group, 20% experienced wound complications, a fact that favors non-surgical treatment in these instances. The complications, injury to the spermatic cord, can occur during surgical lengthening of the adductor longus if dissection is carried medial to the gracilis origin on the pubis. Rehabilitation, post-operatively, patients can bear weight as tolerated with crutches until non-antalgic gait is achieved. Gentle range of motion exercises may begin as tolerated. Strengthening exercises may begin at 6 to 3 weeks with a mean return to play of 12 weeks. Osteitis pubis. Osteitis pubis is thought to be a stress injury of the parasymphysial pubic bones, secondary to increased strain on the anterior pelvis. It is described secondary to chronic overuse, resulting in stress reaction adjacent to the pubic symphysis, and later leads to symphysial pathology. This was demonstrated in a study of pubic rami bone biopsies of athletes in whom osteitis pubis has been diagnosed. The specimens showed formation of new bone formation, woven bone, osteoblasts, and neovascularization, with an absence of inflammatory cells and no signs of osteonecrosis. Osteitis pubis is seen most commonly in athletes participating in soccer, Australian rules football, rugby, ice hockey, American football, and distance running. Clinical presentation, patients often present with lower abdominal pain, bilateral or unilateral groin pain, and for pain over the anterior pelvis. Initial symptoms are similar to those in patients who present with athletic pubalgia or adductor strains. Patients also have tenderness to palpation over the pubic symphysis and adjacent rami. Pain also can be experienced in the perineal, inguinal, and scrotal regions. Patients may report a clicking sensation over the anterior pelvis with activity. Pain is usually aggravated by running or cutting activities, loading of the rectus abdominis, and resisted hip flexion and adduction. Osteitis pubis is often a chronic condition that can result in an inability to compete in athletes secondary to pain and discomfort. This presentation is distinctly different from osteitis pubis presenting with disability during daily activities and a waddling gait, which is seen more typically in females. So you should distinguish between the two conditions. One secondary to sports, other that occurs quite often in females. Examination findings commonly overlap with athletic pubalgia and adductor strains and include tenderness to palpation over the pubic symphysis and pubic tubercle, adductor origin, tenderness, and pain during resisted adduction. Patients may have apprehension during hip range of motion. Patients with reduced hip range of motion are also more likely to have osteitis pubis because it is thought to cause compensatory stress at the pubic symphysis. Imaging. The initial imaging study or evaluation of osteitis pubis is plain radiography. A well-centered anterior-posterior pelvis radiograph will be normal in acute cases. Chronic cases, those lasting more than 5 months of osteitis pubis, can present with cystic changes, sclerosis, or widening of the symphysis. A single leg stance, anterior-posterior flamingo view of the pelvis can be used to evaluate for pubic instability. Widening greater than 7 millimeters or vertical shift greater than 2 millimeters indicates instability of the pubic symphysis. Radiographs also should be evaluated for the presence of femoral acetabular impingement, stress fractures, and avulsion injuries. Let us see over here. Over here, you have femoral acetabular impingement plus a pubalgia, or what you want to call a pubic symphysis, which is inflamed, that occurs in women, or that which occurs in sports. Now, the X-ray is shown for a fellow who's a hockey player, and you see that there is a widening of the symphysis pubis and an elevation on one side. And you see that there's a crossover sign on the right-hand side. So you can see that the crossover sign is corrected on the other side, and you should realize that this patient had a femoral acetabular cam, which is associated with the osteitis pubis. So pay attention to this. They can occur in association with one another. MRI will show subchondral bone marrow edema similar to that seen in osteoarthritis of other joints. The edema is usually bilateral, but often will be asymmetric with increased signal intensity on the more symptomatic side. This shows you a case where you see a chronic osteitis pubis, and you see that it is more so on one side, but both sides are involved, have an increased signal intensity in the area. Treatment, non-surgical treatment. Non-surgical management consists of rest, ice, non-steroidal anti-inflammatory drugs, activity modification, corticosteroids, or PRP injections, and physical therapy focusing on core strengthening. Currently, the evidence for non-surgical treatment of osteitis pubis is level 4. In a prospective cohort study, osteitis pubis was diagnosed by physical examination and MRI in 27 professional Australian rules football players. Treatment consisted of swimming and upper body activities as tolerated. Core strengthening and cycling was started at 3 weeks in patients who were relatively pain-free. Stair stepping was started at 6 weeks with a graduated running program instituted at 12 weeks. Surgical treatment. The surgical treatment of osteitis pubis is indicated primarily for demonstrable instability on radiographs or failure of prolonged non-surgical management. The techniques that are described in the literature for the treatment of osteitis pubis include curettage of the symphysis, wedge resection, mesh reinforcement of the symphysis, arthrodesis of the symphysis using compression plating, broad pelvic floor core muscle procedures. Complications of the surgical treatment of osteitis pubis include hemospermia, scrotal swelling, continued symphyseal instability, and chronic anterior groin pain. Rehabilitation. Post-operatively, patients are initially kept non-weight bearing, gentle range of motion exercises, and stretching are instituted once pain allows. Patients progress through a graduated strengthening program with return to activity as tolerated at 45 weeks. In summary, the understanding of athletic pubalgia and groin pathology is constantly expanding. Previously, they were seen as several isolated pathologies, but substantial evidence now supports the overlap of intra-articular and extra-articular hip and pelvis disorders, as well as other compensatory disorders up and down the kinetic chain in patients presenting with groin pain, as the ability to diagnose specific groin-related pathology improves. Precise treatment of these disorders will help to optimize results and minimize disability times in this challenging and demanding patient population. Based on the evidence supporting an overlap between athletic pubalgia and femoral acetabular impingement, athletes presenting with groin or pelvic pain should be evaluated for both entities. A critical aspect of treating patients with combined intra-articular hip pathology and athletic pubalgia, adductor strain, or osteitis pubis is deciding whether patients require treatment for both entities. This is a challenging scenario because a point likely exists at which treating femoral acetabular impingement alone is inadequate secondary to advanced injury to the anterior pelvic musculature and or structures. The key study points, the key anatomic structures involved in extra-articular hip pain should be identified. Key physical examination findings differentiate intra-articular and extra-articular hip pain. An understanding of the diagnosis and treatment of the various causes of extra-articular hip pain is imperative. Thank you. I want to ask whether there are any comments from first of all, the doctors, the professors, and the students attending. How can we improve his lectures. Are there any comments?
اوكي، مبدئيا يا دكتور نشكرك، طبعا محاضرة ممتازة جدا جدا واستفدنا جميعا منها. الكلام موجه للأطباء الزملاء وطلبة البورد من الدكتور جون. أي استفسارات أو اقتراحات للمحاضرة؟ أي واحد يحب يدلي بدلوه يكتب في الشات ونفتح له المايك.
How can we improve the lectures? I expect to have a comment. Huh? Look it, I'll tell you why I chose to give this lecture. Believe me, when you listen to this lecture, you ask yourself how many times you've made the diagnosis of a hernia. And this was wrong. This was wrong. You should go into the history and see if this patient is undergoing any sports or doing any activity that is causing this situation. You should not think of a hernia. These are the results of injuries, tears, or due to pressure occurring on the area of the muscle or tendon, or ligament tears, or capsular tears. You have to think of the intra-articular pathology. You should look, how many thought that the ligamentum teres was associated with instability if it's cut of the hip? How many thought of it? You have to know the anatomy of the ligamentum teres. You have to know of how it can be injured. You have to know about the labrum, that it functions like a disc. It is a shock absorber. You have to know it deepens the articulation. Don't forget these points. Don't forget about certain symphysis pubis problems, irregularity. Don't confuse it with the osteitis symphysis pubis that occurs in women. I stress this point in these lectures. You learn a lot because many times we are given false information and we think that there are other diagnoses. Whether you will become famous or not will depend on how well you diagnose these conditions and how you manage them. Believe me, I'm telling you this from experience. I'm an old man, and this is from my experience. Many times you have a patient who has been going from doctor to doctor and not knowing what he had. And then suddenly he comes to you, and listening to this lecture, you make the diagnosis. You will become a great man. So keep these in mind. And really, if there's any questions, Dr. Khalid has my phone call, Dr. Abdul Salam also, and Dr. Salah have. Feel free to call me if there are any questions you need answering. We will answer them together. Mind you, there are certain topics I'm learning together with you. I'm taking my lectures from various sports books and journals. Believe me, this is education is by teaching and listening. So thanks a lot for bearing with me these 4 hours. Thank you.
شكرا.
باي باي.
شكرا دكتور، ومحاضرة صراحة ممتعة تغني عن الرجوع للتكست بوك للأمانة يعني، والشباب كلهم الأطباء بيشهدوا بالموضوع هذا. شكرا جزيلا دكتور.
خليهم يدرسوا لأن جايين فحص. لا ببعت هلا كان عندنا الفحص البورد، فما صار معي وقت to prepare new questions. I want to prepare 20 new questions on this topic and give it to Dr. Khalid or Dr. Salah or Dr. Abdul Salam. They will have these questions and put them and add them to other questions that I have sent them, and you will have an exam. My advice to you, my personal advice, of teaching over 50 years at several important universities in the world, I'll tell you, you cannot benefit from a lecture unless you go and read it immediately following listening to it. Otherwise, it will go from one ear and go out from the other ear. So please remember what I'm telling you. You are the future, and the future will depend on how much knowledge you know. You have to be fighters. I'll tell you, in the exam, I was behind the Yemenis, and I want them to be top students. I want them to be good candidates. But there is a point. I saw one Yemeni, he was answering the question and was afraid to look at me. This is wrong. When you are answering a question, you should look directly into the face of the examiner and say, I know much more than you know, and give a proper answer. يا شباب، يمن في مستقبل. يمن كانت بحالة صعبة، حروبة كل الوقت، بس أنا أكيد إنه فيكم توصلوا بإرادتكم، بإرادة ربنا وكل شيء. يلا. I wish you a very good luck and thank you.
Thank you very much, Doctor. في أمان الله.